Hello, everyone. I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. Today, we have a really special panel. We have Dr. Eve Bloomgarden. She's COO at Impact and also CDO of Women in Medicine. And we have Dr. Subha Airan-Javia. She is CEO and founder at CareAlign and a hospitalist at Penn Medicine. And Shane Danaher, he's COO at Divurgent. Welcome.
Thank you,
Thank
John.
you.
We're excited to be here.
Thanks.
Yeah, so excited for this discussion. Before we dive into the topic du jour, if we will, everyone burnt out and all the burnout that's happening in healthcare. Hopefully everyone's not burnt out. But tell us a little bit about yourself and your organization. Subha, why don't you start?
Sure, thanks. So I'm Subha. I am, as you mentioned, a hospitalist and a clinical informaticist at Penn Medicine. Been there since residency about 15 years ago, and pretty early on got interested in using technology to improve the clinician experience and improve patient outcomes. So had the good fortune of working on some projects as a resident, which have now turned into a spin out of Penn, which is CareAlign, the company that we founded, and really we're dedicated to making it easier for clinicians to do their job and to do their job well so that patients have better outcomes.
Awesome. Eve, you want to go next?
Yeah, thank you so much for inviting me to speak today. I am Eve Bloomgarden. I'm an endocrinologist in the Chicagoland area, and I also am part of the leadership teams of two different nonprofits, which both actually intersect with the world of burnout. So Women in Medicine, which is a national nonprofit with a goal to achieve gender equity in medicine, and Impact, which is an advocacy organization that came together at the start of the pandemic to counter misinformation and communicate with the public.
Awesome. Great to have you, Eve. Shane?
Yeah, thanks, John. I've had a background for a couple decades now that really started in driving IT implementations in healthcare. And it gave me the opportunity through the first half to 3/4 to really understand, the why around those IT implementations. And over the past few years and all the experiences that healthcare as an industry has had has really enabled me to have this great passion around taking that knowledge of how to implement IT in healthcare and align that with the right answers for the why that makes sense in some of the crises that we're seeing in healthcare today.
Yeah, absolutely. Well, Eve, let's start off. Yeah, I mean, I think the two doctors should talk first, right? What is the real cause for burnout for physicians? And don't tell me it's yoga rooms or anything like that.
No, how much time do we have, John?
We have plenty of time. What do you see, Eve? What do you think are the real root causes of the burnout that's happening?
So I appreciate this question, and I'm sure that you'll appreciate that the answer I wish could just be one simple thing, but it's certainly not. I think it's the intersection of multiple different pressures that are, placed on the healthcare workforce. And so some of them are, the politicization of science and, the stigma of mental health, unrealistic expectations. We have, a lean healthcare system that was really stripped bare during a global pandemic. We have the explosion of data entry and data analysis when it comes to our healthcare IT, and aside, and in addition to that, time pressure to read more, do more, see more with less time. We have lack of feeling supported and feeling disconnected from the missions of your organization. We have discrimination, we have physician harassment, and then we have limits on flexibility, and we have we have the kind of the cognitive dissonance of trying to do a job that ultimately is an altruistic job where you're made to kind of have to make decisions that go against what you're morally and ethically driven to do day in and day out. And I think when you put all of those things together, here we are in 2022. So the most complicated answer to your question that I could possibly give, I think.
No, I mean, it's, I was going to say that's all, right? Which is, it's a lot. And I think what's interesting is in technology, the most exciting things are this confluence of technology coming together. But in this case, you're describing this confluence of adverse events and outside political pressures and financial pressures and other things, right? Misinformation you even talked about, right? That makes it extra challenging, which is the opposite of what's happening in the tech world. Subha, what would you add to it?
Well, that was a very comprehensive answer, so I'm glad, Eve, that you went first. But I guess I would add the lack of agency, which probably, threads through a lot of it does thread through a lot of the things that you spoke about, Eve. But, lack of being able to make decisions about the tools that you use at work, the time that you work, the time that you get to spend with patients, being able to decide on what should the initiatives be that you work on as an individual or as a group when you're providing care. And, I think the lack of alignment of priority sometimes between the business of healthcare, which is a real need, right? It needs to be a sustainable endeavor, with the mission and how we deliver care. That mismatch often causes a lot of, as you said, dissonance. But I think we've been having a lot of conversations outside of this as well. I started an interview series called Sharp Conversations, and almost in every one of them, someone mentions agency and how, not being able to make their own choices has really affected their wellness and their ability to have a good quality of work life.
Shane, what would you add? I mean, you're obviously working with a lot of clinicians, implementing a lot of technology. What are you hearing and seeing?
Yeah, well, and certainly, I have not earned the ability to have the answer to the question as a non-physician. But what I do know is, working alongside clinical organizations as we've effectively added so much change to the daily, weekly, monthly role of clinicians over the past couple of decades with the technology that you were just referencing. I think there's agency is a neat way to talk about it from the perspective of a physician. That on the sort of the other side, from an implementing perspective, I have to ask the question, did we really do these things thinking about the physician and clinician experience along the way? Was that really effectively computed into the North Star, a lot of these things? And how can we go back and reassess some of those and use the technology and the data that we've consumed today to find the right way out of a little bit of a quandary that we find ourselves in?
Yeah. Well, you both started shaking your head vigorously. And no, clinicians were not consulted as we implemented this. Anything you want to add there, Subha? I mean, as I look at it, right, everyone loves to blame the EHR. And I've always said the EHR is a reflection of the systems and the processes and the requirements and the reimbursement requirements and the regulatory requirements. And so, I always ask the question, do you hate the EHR or do you hate the system that it's reflecting? What do you think, Subha? And how, should we have consulted more clinicians about this?
That is a really good question. I have a lot of answers. I'm going to try to keep them summarized. But no, I don't hate the EHR. I think we absolutely needed to digitize health records. We absolutely needed to move away from paper charts. There's so many wonderful things, often many of which we take for granted now. As a resident, I had to really worry about medication interactions, and I had to really worry about allergies, and have I checked all of these? And these are things that we take for granted that our systems do for us automatically. So many benefits. But people often think physicians hate computers. It's not true. We love technology. The entire field of medicine is supposed to be cutting edge. But when it comes to the tools that we use, they're pretty archaic. Many of them are pretty archaic. They don't change fast enough. And I think part of the challenge is we don't have a tech stack in medicine, at least not for the delivery of care. If you look at the business of healthcare, you have your loss and accounting systems, you have your coding systems, you have all of these other systems built for all of the different people who are supposed to be managing the business side of healthcare. But when it comes to the delivery of care, everything we do is supposed to be in the EHR, and nothing ever should be outside of it. And the reality is it's just not enough. One system cannot do everything we need. And to your question of should we have asked more clinicians, and I'm specifically saying clinicians because it's not just physicians, but every clinician, every frontline practitioner has a lot to offer here. I think there have been a lot of clinicians involved. There's been a lot of migration or morphing of what we thought we could do with technology when we first built EMRs versus what is possible now, and very little change. If you look at even just the way every website looks now as opposed to 15 years ago, they're unrecognizably different. But our EHRs are the same. The way we as a society expect to ingest data digitally is completely different now than when our EHRs were built but our EHRs are still built to mirror what we did in paper. So I think now we're at this, tension point of we need systems that work differently, and they're just not that easy to change. I absolutely think we need more clinicians involved, but it's not just any clinician. I think there's a reason. That's why I did the informatics board certification, is because there is a skill to learning how to design technology, how to develop it, how to implement it, how to do it in a problem-focused, user-centered design way that I think we're missing a lot of.
I think that's such a good point, because every EHR and every health IT system has doctors on their team and that they've consulted. So the question was actually probably incorrect. Do we ask enough physicians? To your point, I think you actually made it so well. It's not did we ask physicians, did we focus on the right thing? And what you said is we focused our IT systems on the financial and the accounting and then the revenue side, and not the tech stack for physicians. Eve, what would you add there? And how would you describe what is the tech stack needed for a physician to be successful and to love the technology?
So what I would add first and foremost is that there were many clinicians involved in this, but who were they and who are they is not representative of the entire population of frontline providers. Meaning, the way that I, as a endocrinologist, outpatient cognitive specialist, uses the healthcare, tech system is very different than somebody who's, a neurosurgeon or a transplant surgeon. And it is also, so you have a lot of representation of certain groups, but you don't have somebody who is fully and completely dependent on the EHR as the only tool to do their job, which is someone like me. And like Subha, right? I mean, so my entire job depends on my EHR working. I can tell you that it's not working right now. And I can give you a really good example. So if I see a patient who happens to have gotten their care in the system that I'm logged into, I can get the data I need using a couple of quick commands and codes to bring in everything I need in a few seconds and analyze it. Because I'm a chronic disease, specialist. I look at things over time. I need to see the pattern. If somebody comes from a different system, even using the same EHR, I cannot get that data without going into, a Care Everywhere, clicking each individual button, writing it down on paper, and then rebuilding it into my screen. And I will tell you 50% of my patients I'm doing that for. So it is, something that I could do in 5 minutes. It now takes me 35 minutes to do, but we have not adapted or adopted any sort of flexibility in the way that our clinic is scheduled or in the expectations of productivity to account for all of this manual data entry that is required to assess the patient. And so, it's incredibly draining, for me to take care of a patient in the hospital. There's not one page that has the info I need. I have to dig through notes in different sections. And, I want to be able to say, Siri, show me this, and this, the way I could do for anything on my phone, and I can't do it. So that's, I think, a huge piece of it is where are the cognitive specialists who only have this tool, and why don't we get a say in if our tool's not working for us, and why is our workflow being designed for a tool that is working against us? And then the other thing, I will say is the experience with our patients and how they communicate with us through the EHR. So patients are living in a world of 2022 technology where they want to have easy access to their records. They want to engage electronically and communicate electronically with their care providers. And now we're mandated to do that. So they're getting their results, they're sending in messages, but we haven't increased our staffing or our ability to address any of that. And we haven't adopted a way to pay us for our time. And so we are just being flooded in all directions with data and with expectations that reflect the technology that exists in 2022, but we're still using outdated technology until we can't give back what they're expecting. And that creates even more patient dissatisfaction.
Wow. No,
Yes.
that's an extra burden for sure. All those extra messages and how do you compensate for it? But I think your first point is fascinating as well. And that's, Shane, you probably face this at Divurgent. There's like, okay, there's 50 specialties, and then obviously pediatric specialties within those subspecialties of, and the EHR needs to solve for all of those. And while Eve wants to have the whole longitudinal record, someone else with a acute issue maybe doesn't want all that info because it could impact it. How do you navigate that, Shane, when you're working with people?
Well, I think there's a couple different ways to look at it. This conversation always gets me excited when we start getting here. You look at what we did in the last decade with EHRs, or a little more than a decade, if you want to go back to the beginning of to ARA. And I'd maybe say that it's a hair pessimistic to maybe say that we did it wrong. And I think a lot of it is pace, right? Like healthcare has a tenuous relationship with big dollars. And so to move the needle in what healthcare was using as technology, there was a moment in time around meaningful use in ARA where we had the ability to get it right. And you had a lot of organizations that spent, and I don't just mean money, but also internal political capital and all sorts of other capital to get their EHR installed. And the reality is that was just getting everyone to the starting line, but it exhausted all of these healthcare organizations to the point where we implemented a book of record for a portion of the business, and then assumed that everyone could do their job in the book of record. And like Subha was saying, if you look at other business operations, that's not how it works. There's a book of record, and there's places where work gets done, and there's not really a corollary in healthcare. And Subha, I'm pulling on some of the great
It's called paper.
Months ago.
Paper, the most flexible documentation solution out there.
Yeah. But I think, in answer to your question, the work's not done is the unfortunate answer to it. And I think we all need to know that. I can't tell you how optimistic I am when I hear Eve talk about some of the things that's frustrating and use words like the experience that's being done. You're starting to see, and not really starting, there's a lot of organizations, healthcare organizations, that are starting to recognize the experience. Now, I'd argue that maybe a lot of that is being spent on the consumer experience, and we need to make sure that there's a reasonable and a right amount also on the clinician experience. And Eve, you were talking about, the digital front door, right? So, great. I mean, you can put a digital front door up and it's going to make an awesome patient experience, but how's it working out for the physicians and the clinicians?
And what happens when they get in that door?
Yeah, once they get in the door and they see smoke and mirrors.
Well, I can say, from having the opportunity to be a part of a conference a couple months ago on physician marketing strategies, which was essentially, trying to figure out how to connect with the right patients in the area. The lesson learned from every organization that had like a little pocket of digital excellence that they had developed was, you will fail at this if you don't partner with clinical operations. Yeah. And so that when I left that, I honestly had a lot of optimism about the future of healthcare, because it was like, this is cool, because I think there's getting to be some harmony around what the problems are, and organizations are starting to figure out how to address them via things like reevaluating or editing or adding to their tech stack, which Subha, I agree with you on this. I mean, there is no tech stack on the clinical side. There's a book of record that must change.
Yeah. If I could add something to that, John, you were asking, you have so many different specialists, so many different workflows. How do you build technology that meets them? Sometimes, like I said, you're not going to have one that does everything, but at least in our experience developing CareAlign at Penn, it's used across 170 services. So surgery, floor, ICU, OB, medicine. And at every implementation that we did with every new service we worked with, it really, everyone had new ideas they wanted. They said, we need to be able to do this. You need to fit my workflow. And at the end of the day, we were able to really use the principles of, QI research and really figuring out with the 5 whys, what is the real problem that we're trying to solve for. By doing that, we were able to say, okay, what is the real need that you have here as a clinician? And then design for that in a way that then everybody could use it. There is not one thing that we built that was specific only to one particular service. And at the end of the day, if you build things the right way, I believe, everybody can use it. Now, sure, there are going to be areas where I don't need to see intracranial pressure for a patient when I'm on the floor, but the technology can automatically hide that when I'm not there. So I would love to see more technology systems instead of saying we need to specialize everything and make it unique for every single group of clinicians and for every single clinical setting, say, let's learn about what the needs are and what that means from a foundational perspective about delivery of care, and build that into the platform in a way that then everybody can benefit from it.
Yeah, I would say I completely agree with that. And I think, something that may not be obvious, when you're designing a system, is that even something as simple as giving us the ability to hide unnecessary information would be incredibly useful. For example, I think when I first log on to my system, there are 2 rows going vertically, 2, and then another when you click into a 3rd row horizontally. I use 4 of those buttons. None of them are visible until I get into the weeds. And so I can be looking at 19 different sections of data in one screen, except the reason the patient's seeing me is not there. So the ability to customize at the user end, and the ability to only see what you need to see, and you can always look further. But the fact that we are having to dig through a pile of sand to find, pile of hay to find the needle in the haystack every couple of minutes is really trying on everybody. And I think it is, no other organization or no other business would work this way, where you just are relying on your workers to go home and spend hours after they put their kids to bed or do their evening activities, just getting back on to sort through the muck. And that is, I think it kind of speaks to the fact that burnout is not a resilience deficiency of frontline providers, right? Nurses, doctors, respiratory techs, pharmacists, we're pretty resilient people. Yeah. We got through a lot of training. We've been dealing with a lot over the last few years and even before then. And we are living in the intersection of multiple enormous forces of, within science, within politics, within policy, within, economics. And I think we're still here. But this is a fixable problem that nobody seems to feel the same urgency that those of us using it are feeling. And so we're not seeing kind of the messaging on the urgency of meeting the people who are at the front line. And I think that's causing a lot of people to just decide to leave healthcare.
Yeah. And I think the hard thing for me, from my view, talking to so many people and their experiences, is the experience isn't equal, right? To Subha's point, when you figure it out and you get it right, they don't chart at home at night, right? They finish the charts before going home, and you see that, and
it depends on how you get paid, right? So if you're a surgeon, you get paid for operating, and the EHR dysfunction or functionality is much less important to your bottom line. You probably have somebody doing a lot of that for you. If you are, well staffed, if you have multiple, if you have nursing and medical assistants and people who can allow you to do your job to the top of your license, the dysfunction is less of a problem. But when you are already really strapped for assistance and help, and it's the only tool and everything, the only way you get paid is by using the EHR, that is where you see the biggest pain points. And we see this in disproportionately in women, compared to men or those identifying as women versus men. And we see that because we see more women in specialties that are highly dependent on the EHR. And so what we're seeing is kind of this mass resignation from healthcare, and the majority of people leaving are women. And so, and it is because I think we have this disproportionate, there are more men in surgical fields than women, and they're less dependent on the EHR, and they're less dependent on using the EHR to bill for what their job is, and they have more support. And so we see this kind of occupational and gender segregation that drives burnout, that's having a disproportionate effect on those who are relying on the EHR the most.
100%. And then you mentioned this last time we spoke about the difference in message volume that female versus male physicians get from their patients, or even from their staff, right? The threshold of reaching out to your physician is different depending on their gender. So that just adds another layer of work. And one thing I wanted to kind of add to what you were saying, Eve, is that at the end of the day, as you said, we are here to help people. And so at the end of the day, physicians are going to, and clinicians are going to do whatever they need to do to help their patients. And it feels like the entire healthcare industry counts on that and leverages that and says, okay, there's this need and this need and this need and this need. At the end of the day, well, it'll get done because the doctor's going to have to do it, because not only do they care, but also the liability ends with you, right? So, it's that's where the incentives are really not aligned well enough, that we're never going to just up and leave and be like, peace out, I'm not going to, do what needs to be done for this patient. Although, engineers can do that. Other staff can do that. They can be like, I'm done. You have to pay me overtime. I'm not going to stay here an
Right.
extra 5 hours. But clinicians can't do that.
We
And won't
can't do it. We can't switch specialties. A lot of us have a ton of loans, that kind of lock us in. We have non-competes that don't really exist in other industries that kind of prevent us from being able to move companies or organizations without uprooting our families. And so there's a lot that prevents us from leaving. And I think this was all pre-COVID, right? And then we have fear of getting, getting mental health treatment because we're worried about losing our license. And so you have, there's all these things that prevent us from asking for help and that prevent us from moving or acknowledging when, when we really need a change. And we, and then we rise to the occasion to during the pandemic and spend 2 years really just giving even more of ourselves. And I think that is why, now we're starting to see truly the effects of the great resignation on healthcare. And it's very noticeable when a patient comes into an office, anywhere now, they'll notice, how come it takes so long to call me back? Or how come there's only one person at the front desk? And, it's the experience is being felt now at all levels. And I think it is, people have gotten to a point where they're just realizing they can't do it anymore. And I would say I get multiple calls a week from colleagues and from people who just reach out to me through social media or through one of my organizations, just asking, what should they do? I certainly don't have all the answers, but I'm a listener, right? So, we can try and just support people through this really challenging question. But as physicians and nurses and anyone who really has their identity is wrapped up in their profession, and it's hard to separate. It's very hard to realize it's very hard to take the next step when you don't know what to do next, but you're miserable in your current situation. And the EHR does play a very significant role, unfortunately, in that day-to-day misery for many of us.
Yeah. Well, it's interesting you say this. I literally recorded a podcast yesterday about workforce, right? And workforce retention. And I hypothesized that it may not be as big an impact on the healthcare workforce versus the health IT workforce, because when you have an MD or an RN, you just don't have as many other options, to your point, Eva, right? That, you're so invested in it from, literal financial years, et cetera, that it's harder to go other places. And so you kind of have to come back in some ways. So yeah, go ahead, Eve, if you.
Well, I was going to say, but you don't have to. You have the option of leaving medicine. And so
right.
That's what's happening, right? And so instead of retaining these very, very highly specialized and these knowledge workers who really have a service and have the ability to offer something that many people don't, instead of retaining that person by providing the flexibility and providing the sense of being valued and providing some tech support or providing whatever it is that is needed, we're seeing a doubling down on not being flexible and not changing things. And when you are being asked to do your job, but you are given no tools or assistance to do it, there does come a point where you cannot do your job anymore. And at that point, a lot of people are walking.
I have a question, John. When you said you have a feeling it doesn't affect clinicians as much, did you mean the EHR?
No, I mean that it's possible that many of these clinicians may take a break, but then come back because their degrees are so, valued and, and you can't take it. Certainly you could go to vendors, you could do some other options, right? But it's harder to translate, an AI specialist could go to another industry and do just fine, right? Doing AI, but a doctor has a hard time going to another industry because it's so specialized, the training. So that's the argument.
I think that's true, but mostly true. But I do think, as Eve said, there have been so many more people just saying they're done. with medicine, and they will explore other things. As we've pointed out, we are very resilient people. We'll figure out something else to do. We can learn. I can't tell you how many colleagues, who both new colleagues and long-term colleagues, who've come to me saying, what opportunities are there for me to use my clinical experience outside of clinical care, and to try to make the system better. But it's just, it's striking.
It is. No, absolutely. And I mean, the real question is, how do we improve this, right?
Yeah.
You know,
exactly.
and the workforce retention is the number one topic on everyone's lips, right? So Shane, what do you think? What, you know, how do, you know, leaders make this a key priority? And what does, you know, I think it's interesting, Eve saying EHR is a major part of this problem, right? And how can the IT selection, the implementation, the workflow, how does that play into it?
Well, first of all, there's this saying, the first step of solving a problem is admitting you have a problem. And so, you know, again, I'm happy that I'd say, you know, the overwhelming majority of conversations that I have the opportunity to have with healthcare organization leaders, they're identifying workforce retention in and outside of clinical professions as one of the single biggest issues that they're addressing over the next couple of years. And currently, unfortunately, I think, you know, there's data also out there that suggests that we're not yet improving it. And in fact, it's actually going in the wrong direction. You know, there's a good stat, and I can't remember the exact percentage, but it was enough that I would describe it as staggering percentage of practicing clinicians that self-assessed that they lacked the actual training and IT skills to use the tools that they have to use today. And that's notwithstanding the tools that we'll ask them to use tomorrow. And so, you know, there's a lot that goes on there, and that's not necessarily to call out training as an issue. It's not necessarily as simple as saying more training. It's a more nuanced and complicated issue that it goes back to some of the things we talked about earlier in here about creating governance models that really, you know, value some of the things that Eve said as well, right? So, you know, I go back and look at a lot of the EMR implementations that we've seen and where they did have good clinical governance structures. You know, there was probably a relationship in the clinical governance structure to revenue centers in the organization, which was probably surgeons. You know, and maybe there wasn't enough governance that was really coming from all of the specialties and areas of clinicians that will ultimately use the EHR. And Eve, I love when you talk about how that's topsy-turvy with, you know, the impact that the EHR has on a daily workflow. That's a really interesting vantage point that, you know, I think more people need to hear. So yeah. I'm glad you keep saying it.
I will continue to say it, you know,
yeah.
I think absolutely. But you know, I've worked now in 3 different systems with the same EHR over the last 12, 13 years, and each system is completely different. We're not allowed to borrow or to, you know, we can't really like copy each other's, you know, systems. So if you know something works, but you're not in that system anymore, like you have to build it again from the beginning, meaning you have to figure out if there's a tech person who's even going to answer your ticket, and then you have to tell them what you want. And that might take a year or 2. All the while, you know, you are coming up with elaborate workarounds to be able to do the job that you are trained to do. You know, and I think when you add, like, you can't forget what else is going on. I mean, patients are coming in angrier. There's a lot more like physician bullying. There's a lot more harassment. It's coming at us from all sides, you know, online, in the news, social media. You know, we have we have an epidemic of gun violence that's, you know, puts us in a space, you know, I work at Highland Park Hospital, like, you know what I mean? Like, I mean, there's like a lot that's happening in the day-to-day. Our kids are at school, you know, women just lost their constitutional right to bodily autonomy. There's all these things in the background that I only say to mean that, like, patients want to talk about that. That's affecting our patients as well. There's, like, you know, things are showing up that were not showing up a year ago in the office in terms of needs and you know, our patients are also a lot sicker because they maybe missed some of their appointments. And so to use a system that worked 3 years ago with technology that worked 7 years ago, you know, there's just, it doesn't even make sense. Like, we have to be able to radically redesign the way that we're delivering care, or we are going to lose a very talented, highly trained healthcare workforce. And, you know, I think we have a ways to go to be able to really get to where we all thought we were, right? I mean, I think we've lost a lot of ground, and now we are dealing with a very short workforce and very sick people and very much less assistance. And, I think the Surgeon General did a really good job with a recent advisory that he put out on burnout, where he really outlines like a variety of interventions to be done at various levels, most of which have nothing to do with changing the frontline provider, right? I mean, so again, I've said this on many recordings and in person, but yoga is lovely, but is not the way to fix this problem, right? I mean, it's not, you can't yoga your way out of a systems issue. And when you add additional pressures, and we also have expectations of, what physicians and nurses are supposed to be doing, it's too much unless like we're going to see somebody else show up and help us. And I think, unfortunately, a lot of us have been very disappointed in the lack of the tech world showing up in the same way, right? I mean, if I call somebody and I need help and I open a ticket, like they can't help me with some other problem, only what's on the ticket. And they might call me back 3 weeks later, and that the system I've already figured out a workaround, to not have like a national workforce or some sort of like, generalized healthcare IT person to be able to help you in real time, across the country is really a failure, I would say, on the tech side. So we're showing up, but nobody else seems to be as invested. And maybe it's because we're stuck and we can't go somewhere else, but like, the level of altruism disconnect, I think, and the level of like, well, I could just leave this job and I don't need to help you. It's just different. And I think we are all seeing, multiple systems around us letting us down.
I have to say, I think we've talked a lot about how technology has made things difficult. There's so many ways that technology can make things better. Anyone walking on the HIMSS floor or any health tech conference, there's, thousands of different options. There's a lot of them that are focused around the business side of things and around diagnostics and therapeutics and consumer, much less focused on the clinician workflow and experience, although it's growing. I think practically speaking, no one's going to say, let's rip out the EHRs. No one wants to do that. They are now the foundation of what our systems are built on. But what I believe they now enable us to do is, as you said, Shane, a really exciting time for change and saying, okay, great, we now have things digitized. That means it's accessible and usable, and we can make things better with it. What we need to change, I think the starting point is the culture around it's okay to be, not only it's okay, but we need to be able to use technology and tools that are built on top of or alongside or with our EHRs for the delivery of care, because what we have right now just within the EHR is not enough. There are so many things we can do already. And even when I hear you speak, it really, as the CEO of a tech company, it kills me, because if someone, and I did this well before starting the company, for the 8 years that we were managing this, I was managing this at Penn with my team. If someone messaged at 4 a.m. and I happened to get up and see it, I called them back, because I understand what it's like to be practicing and on the floors and needing to figure something out and you can't get someone to help you. We have to have the level of customer experience from the clinician side with our tech companies that you do in the rest of your life. But it's non-existent. I guarantee you the vendors are picking up the phone when someone from accounting picks up, or RCM picks up, or HIM calls them. The other thing is, I think in general, vendors need to be expected to do better, especially the bigger vendors who are getting paid billions of dollars to be the foundation of our systems. It's not okay, in my opinion, to be like, oh, I'm sorry, this is all you get out of the box, so you're going to have to completely rebuild what these people already built. Like, why are we not getting a full package when we start with an implementation of things that we already know work well? And Shane, to your point about training, if I hear people say, oh, we need to send clinicians to more training, I'm just going to lose my mind, because technology should be easy to use. Our children, our toddlers, our infants figure out how to use the phone within seconds. That is the definition of well-designed tech, is I don't need you to sit down with me for hours and teach me. I can figure out the bulk of it just from experiencing with it. And sure, healthcare is complicated, but technology doesn't have to be complicated. So I think we need to really—
if we can't figure out how it works, like we shouldn't have to use it, right? I mean, nobody would download an app that was impossible to use.
Yeah,
I do think
and
there's
how
a
many
couple
people—
good things that are happening for what you're talking about, Subha. I'm trying to be an optimist, right? Positivity.
I'm an optimist. I am not. I'm also an optimist, but
yeah. To be clear, I'm very passionate about how IT can be an enabler, a problem solver, and we're going to get there. But the two things I was going to say is, and these aren't necessarily always good things, but in the context of this conversation, I think they're in the right direction. One, M&A activity in healthcare, right? So you're getting more organizations that are getting more of the same technology, combined with, if 5 years ago, we spent a quarter of our time around EHR talking about EHR optimization. I'm not hearing that. What I am hearing is about organizations that are trying to come up with more standard models. They're re-implementing a more standard model from a vendor. Now, is that the right model to implement? Don't know. But what I do know is that if we can get a more stable platform of how an EHR operates as a book of record at more organizations, it's going to allow for innovation to scale better for what should be sitting on top of that stable platform. And it doesn't exist today.
Can I push on that a little, Shane? Because
yeah, do it.
I think we need to be agile. And I think to a certain extent, EHRs can't be super agile, right? They're more like big, huge cruise ships. And we need to have pockets of innovation that can be agile and be speedboats and change with workflow. But at least the experience I've seen both on the clinical and the entrepreneurial side is people implement their EHRs, health systems implement their EHRs, then they say, oh, now we have to shut everything down because now we're going to optimize our EHR. And now we're going to shut everything down because now we're going to do the next version upgrade of our EHR. And so there's never any space in the IT bandwidth to say, okay, we're able to think about something that's not our EHR. Meanwhile, you have clinicians and everyone saying, here's a great solution. Here's something we can use. Let us use it. But unless it's a box that's required to be checked for some, reimbursement opportunity or regulation, it just doesn't rise to the top. And I spoke with Colin at HIMSS earlier just to say we need more action. Like, people talk about health force retention and people talk about improving wellness, but beyond hiring wellness officers, I don't really see much action around changing or at least improving the things that clinicians, the tools that clinicians have to be able to work with.
Yeah.
Like, I still rely on a fax machine to get records. And that is, I think, the best way to describe what's happening on the front lines versus whatever is happening in meetings about, fancy AI. And there's no plan to get rid of a fax machine. So, I think even if I have a patient who is seen in the state and there's a Care Everywhere thing, I still can't see the images that they just got because they had to go somewhere else for their pictures. And if I want the report, I have to call somebody and I have to wait for it to come through a fax machine. Meanwhile, their appointment ended 2 hours ago, and, they will leave and either be, completely dissatisfied, or they'll stay and I will have 10 other people completely dissatisfied. And the EHR does not make any of that faster. Right?
Yeah.
That's how they used to do it in the 1980s or 1970s. And like, we have not changed those workflows at all. And the EHR just changed the expectation. It just moved every responsibility to the doctor, basically, because we're the ones in the room who ultimately need the information. And because we have, interoperable systems, they think we can get everything. But if we can't, there's no system in place to help. And I think I keep thinking about when you say, the Suez Canal and the Evergreen, ship, like they were just like this giant clunky cruise ships. And like,
it's wedged in.
I feel like there's just like doctors like attempting to go like under the boat or around the boat or over the boat. And we're like, and then somebody's like, why don't we build a bridge? And they're like, that's not on the docket for a couple of years. It's just.
And then they get mad at the doctors for the workarounds.
Yeah. And then, I think it's, you can't be stuck forever. And right now what's happening is it's too clunky to be able to meet the expectations of anyone on either side of the physician-patient relationship.
And I feel like the burnout I hear, hearing you talk about your examples, it is almost doubled or tripled, in the sense that, you worked at multiple organizations that had the same EHR, and now you're at a new organization. So the tech is there to make your life better, but you don't have it, right? Or the tech is there that you can share data.
I will say, like, this is at every institution. There are this very similar issues with workflows, with fax machines, with delays.
Oh yeah.
Every institution has a little bit of something that they're doing better. and a little bit of something that they don't even know exists. And
Yeah.
so, it's not like one. I don't think I've been in a system where I'm like, this is optimized. I've just, I've seen what works. And if you could combine them all, you would have a great system. But we can't do that, right? Even if I have a screenshot of what my friend in California is doing, which looks amazing, I can't get that built, and I don't have the authority to build it myself, right?
Yeah.
If you look
that's
at
the
the
challenge.
I was going to say, if you look at the decision makers in health systems, particularly around tech, right? Usually you need a lot of people to weigh in and say yes, but the ultimate people who can veto or can actually say yes, it's usually the CFO and the CIO, neither of whom are usually clinicians. And at least in the experiences that we've seen, CMIOs, well-being officers, no one has budget. They don't get to, appropriate IT resources and say, yeah, we're going to do this integration. And I mean, if you look at the average software in business, there's like 300 connections to other platforms. That's just the way you do work, is you find the best tool for the job, right? If I'm a chef, I'm going to have the best knife, and I'm going to have a whole block of knives for cutting different vegetables, which seems crazy, but that's how I get to be efficient. In medicine, we're not doing that. I don't care what you're doing. This is what you get to use as a doctor. But there is opportunity. There's so many great technologies. So if we could really, push past the old thinking of one way is the only way, and saying technology enables us to be interoperable now. That's no longer a limitation. We get so much that we can do with it. We need to embrace that and really start focusing on how we deliver care better.
I think what I want to, one of the things that I think I would really emphasize is it's the combination of the way that we are reimbursed, meaning, as much as possible, as fast as possible. So we're paid by how many people you can see in a day, or, and the problem with that is there's no time built into the way that the way that we deliver care that is allows us to get a handle on some of this extra documentation or some of the in-basket or the messaging or the tech. We haven't built that in, and we have not figured out a way to pay us for any of the things that are not billable services. And so, I would not care about the dysfunction or function of the EHR if I had enough time to do my job during work hours. And I think that's the other thing. So it kind of depends on what we value. If we value productivity and turnover, then the system must be better. The tools we're using need to be efficient. If we just want to, if you value the physician showing up and doing their job and taking care of however many patients they can, that, in a certain amount of time that also allows for them to do this other stuff, then the immediacy of fixing the EHR is much less, prominent. It's just, you can't do both sustainably. And that's kind of where I think we're stuck. So what do we value, right? Because a lot of really, really, really good doctors and nurses and pharmacists and advanced practice providers, like a lot of people who are wonderful at healing and at taking care of sick people are leaving because they can't keep going and not be able to also have a family, or, they can't decompress at the end of the day because there's so many IT demands.
Yeah, well, and I think that's actually, we could talk for hours. Maybe we will in the future, but I think that's actually the perfect way to wrap this up, is just to ask the question, what do we value? And if we value the physicians, the clinicians, the nurses that we're with, then this is going to be an extremely important topic for us to address, to partner with the right people that can help us to implement what we need to refine our systems, to improve the clinician experience and workflow. So thanks so much, each of you, for being part of this. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting application. Thanks, everyone.
Thank you.
Bye. Thank
Bye-bye.
you.